This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
What I will try to do in the next 45 minutes is to talk to you about mood disorders in general, and then to make a special emphasis on the familial clustering of mood disorders and on the roots, if you will, of mood disorders in families, where it all starts and how it's all getting to develop. And the emphasis today will be more on women, and it's not necessarily a coincidence, because not only because I am, as you see, in charge of the Women's Center in Neurosciences, but also because women, as you will learn in a minute, are carriers of much bigger burden with regard to mood disorders than men do. Before I'll go into the specifics, I wanted to show you, it's a snapshot from the newspaper. I found it in a coffee room today and asked my associates to make a slide for you. This is really very poignant demographics showing in the regular periodical the rate of major psychiatric disorders in the general population in the United States. And looking in the box, you can see the names of these major illnesses. So schizophrenia is comprising 1.1% of general population, depression 9.5%, phobia, or one of the types of anxiety disorders, is even higher, 10.9%, panic disorder 1.3%, obsessive compulsive disorder 2.1%, somatization and hypochondria is very little, 0.2%, and antisocial personality disorder is 1.5%. And you could see how many millions of people in the United States are affected by these illnesses. So these illnesses are incredibly common. And in fact, I don't know if you can see it, but basically that's what it says here, that severe mental illnesses are more common than cancer, diabetes, or heart disease. And more than 20% of families are affected by severe mental illness in their lifetime. It's a staggering statistics, I have to tell you. If you think about people you know, or maybe your own examples, every fifth family has mental illness amidst. About 21% of hospital beds are filled with patients with mental illness. And this is, again, an enormous number of dollars which go to cover, to treat morbidity associated with the mental disorder. So this is sobering statistics to think that we need to know more and deal more actively with the illness other than just a somatic disease. Now, to earn my keep with my own center, I wanted to pay attention to the specific neurobiology, to the aspects of the brain function specific to women. And what is known is that there are a number of various components which contribute to psychiatric and neurodegenerative disorders in women. And in a minute I will tell you why I'm emphasizing women. So there are a number of biological factors, such as reproductive hormones, which contribute to the central nervous system modulation. There are pre-existing psychiatric events in a woman's life which contribute to the further development of illness. There are a number of psychosocial factors. For example, multiple roles women play in comparison to men. Women who have jobs, children, parents, and other responsibilities, which they all have to keep up with, at the same time being productive members of society and having their roles in the family. In developmental context, which could be biological but could also be just a result of upbringing, that women are brought up in a very different realm than men are, and that in a way also contributes to the development of psychopathology in women. So now, why women? Well, this is the old statistics which still holds true. And that slide basically shows that women suffer from depression twice as often than men do. And that starts early in their lives when the girls reach puberty. And it stays with them throughout their reproductive lifespan until they reach menopause. And at that point, unfortunately, there is additional increase in vulnerability and susceptibility to depression among women, more so than among men. So women are definitely more vulnerable to depression than men are. So what are the impacts of untreated depression? If I were to poll you, the audience, right now and ask you, how many of you ever felt depressed in your life? I would probably see a lot of hands. But what really constitutes depression is not just the constellation of symptoms, but the level of functioning which is associated with those symptoms. And basically, the diagnosis of a clinical depression is really a diagnosis when the function deviates from what is appropriate and expected. And here are the examples of this deviated function level: broken marriages, destroyed property, inability to work, inability to attend to daily routine, and in some cases, unfortunately, suicidal attempts and accomplished suicides. And in fact, in some types of mental disease, and more specifically in bipolar, manic depressive illness, the rate of accomplished suicide is about 15%, and that's a staggering number in itself. So those are manifestations of behavior which results from untreated and poorly diagnosed depression. So where do we start? Where's the chicken, where's the egg? Well, I would suggest to start with women who carry babies, because we have now a very clear knowledge that having depression in pregnancy is a significant risk factor for the offspring, for those babies, to have depressive or other mental disease later in life. And so one of the conundrums we're facing in the clinical psychiatry right now is how to appropriately diagnose and treat depression among pregnant women. And there are two ways to deal with depression when a woman is pregnant. One is to treat and the other is not to treat, right? When you think of treating depression in pregnant women, the question then is whether to treat it with medication or non-pharmacological methods. So would that be drugs, prescription medications, or psychotherapy? In some cases, psychotherapy is very effective, and women do remarkably well. In some cases, women don't need anything, and they can go through pregnancy without being treated, and those cases are rare cases. But majority of cases require medication. Now, drugs used when the risk to mother and fetus from the disease outweighs the risks of that drug. Because we do know that there are many medications which may have its own impact on the developing baby. And those impacts range from congenital malformations in some cases when babies are born with deformities to some behavioral toxicity when babies have withdrawal symptoms or any other potential problems which could arise when they are predisposed to medication in utero. However, what we also know is that untreated depression in a pregnant woman is a very dangerous condition. And patients who have been depressed in pregnancy have even higher chance to be more depressed when they reach postpartum, and we will talk about that. So here is the seesaw of decision making for physicians and for the patients alike, because unlike other specialties, psychiatry is not as paternalistic as other specialties. Psychiatry does not give an antibiotic to a patient and says, take it for 7 days or 12 days and come back. So it is a decision made by the families, by women, with their partners and significant others to just decide what is more important to protect the fetus from the potential risks of exposure to medications such as these side effects I was describing to you, or not to have a viable pregnancy sometimes. And we do know that in many cases, mothers who are very depressed cannot take good care of themselves, let alone of their pregnancy. And that in itself carries a significant rate of obstetrical complications. For example, premature labor and low birth weight. So the rule of thumb for us in psychiatry is to limit the exposure to either illness or the treatment and to help patients to decide which exposure path poses the least risk. Let me tell you a case which was one of the more dramatic cases we had in our clinic. We had a lady who was 38 years old, never been pregnant before, had severe mood disease, and was in a hospital many times in her life, who came to me for a consultation and asked me if she can become pregnant. And I said, of course you can become pregnant, but you have to know about the risks of your illness course during the pregnancy and postpartum. And she said, yes, I know, I researched it well, and I'm prepared to take a risk. And she said, my husband is prepared to take a risk too, and I'm not going to be on medication. And I said, well, it is your choice. You have to know about the percentages, etc. We talk about all that. She stopped the medication she was on. It was lithium. And started coming to the clinic. She had a therapist. She saw that therapist 3 times a week. The first trimester, when all the organs are getting formed, went very well. She did not deteriorate at all. She did fine. Her husband comes in and says, okay, we're past the most difficult time in our lives. Now I want her back on medication. She says, no, I don't want to be on medication. I'm doing well. The husband said, no, I can't take it. I'm anxious. I'm very, very anxious. I can't deal with the fact that you may get worse. Well, we listened to the patient, and she had to deal with her husband at home. She did not receive medication for another 3 months. She comes back again, and she was seeing us once a month. And at that time, she was in the 3rd trimester, still no problems with her mood. And the husband said, I want the medication again. I want her on medication. And The patient says, I'm feeling fine. I don't want to be on medication. And so we kept her with no medication until she delivered the baby and restarted her the first day she was allowed to take fluids. And she was doing fairly well. She did have a mild episode of depression postpartum, but she was able to, she did not breastfeed, and so she was able to protect her fetus from the exposure to medication and to have uneventful pregnancy. She did, however, and that's the point of the story, despite of uneventful pregnancy, she did have a postpartum episode. It was mitigated because we restarted medication right away. But the point of that story is that it is not our decision, it's a person's decision with their family, but the family has to make a unified decision together as a unit. So these are our goals: to protect the baby from any harmful potential risk, but at the same time to serve patients' best interest. Now, one of the reasons why we're very cautious about the pregnancy and about the medication, because the most dangerous time in woman's life with regard to the worsening or new development of her mental illness is the time surrounding postpartum period. And again, you could see here this very, very strong signal in terms of the number of admissions to a psychiatric hospital during the time of childbirth and just surrounding the childbirth. This is a very difficult issue. And for those of you who remember cases, Andrea Yates' case years ago, and recently another case in the Bay Area, I think a year ago, a lady who drowned her children. Those are extreme cases of postpartum depression with psychosis. Regardless, again, of what the exact diagnosis was, these people were not treated during pregnancy, and therefore they had such a severe illness relapse, which resulted in infanticide. And in fact, infanticide rates with untreated, specifically bipolar disease, are as high as 4%. So this is the highest incidence of infanticide if a woman is not treated. So it's incredibly important to do that. Now, as my talk talks more about familial mood disorder, why is it also so important to think about treatment? As we know, all the medications which we have some effects, positive and negative, but they're not completely benign agents. Well, the reason is that, unfortunately, women who are depressed and not treated, their influence of their illness has number of effects on the offspring. And that, if you want to think about the propagation of the insult of mental illness in families, you have to think about illness in the mother and illness in the father, which will have their influence on the child. So parental depression increases the vulnerability of children to multiple negative outcomes, including psychological and physical. Among psychological, difficulties with emotion regulation. Those children are not as well balanced in their expression of emotion as children of non-depressed parents. They have lower self-esteem. They have aggressive behaviors towards peers and parents. They have insecure attachments with parents and lower scores on cognitive functioning. Some of this data is supported by decades of animal research, and I'm sure some of you in the audience probably know the experiments on monkeys by Harlow with maternal deprivation. And those monkeys were clearly raised with the surrogate mothers, and they were not exhibiting similar behavior as monkeys who were raised by attending mothers to them. And just to tell you that in current development of the the early childhood development of mental illness and attachment, etc., we know now that children who are raised by depressed mothers exhibit very similar aberrations of behavior, and moreover, these children are at the risk to develop mental illness at an earlier age than children of mothers who are depressed and treated. So the psychological spectrum of dysfunction in the offspring is really important. But there is also a number of physical caveats. As a woman who does not take good care of herself because she is depressed, she is not going to take good care of the child. So there are a number of cases when you have a parental neglect. And I can give you another illustration, and that is really dramatic. We had a woman in a clinic who was depressed in postpartum, and her husband would not allow her, because of cultural reasons, to be on medication. Moreover, the family structure in that family was such that the husband was requesting to see every single grocery store receipt to make sure that she is breastfeeding their baby and not buying formula. So this lady was not on medication, and her newborn developed torticollis, this condition with the neck, because she was not holding him right. And the baby had to be treated as a result of it, because this woman did not know how to attend to her child. So these are very, very serious issues, and that's how we see this increase in the incidence of childhood and early adolescent mood disorders, which we observe now in the country. And this is incredibly important. So postpartum depression has effects on the mother, on the baby, and other family members, and may lead to chronic illness, including maternal depression, but also including the depression in a child. So to conclude this part, we do need to be very proactive in recognizing how we feel, how we function, not to be concerned to ask for help, and to really establish communications between the physician and ourselves, between family members, between significant others, friends, relatives, explaining where we are if we have a problem with our mood. And there's absolutely no place anymore in, I think, at current day and age, for people to be more concerned about the stigma of mental illness if you consider the numbers which I showed you, that every fifth family in the United States has mental illness within. Now, the reason I want to talk a little bit about aging and talk maybe more specifically now about women again is that what we know in neurosciences is that what happens in the brain when brain has disease called depression is that number of neurons, the cells in the brain in specific areas are getting attacked, if you will, by various chemicals. And specifically, there is a hormone called cortisol, which is a very well-known hormone which is produced by adrenal gland, but really targets neurons in the area of a brain responsible for memory. And when people suffer from depression throughout their lives, and they have episodes after episodes, and they don't treat it well enough, and sometimes even if they do, those neurons in the area of hippocampus, the area responsible for memory, may die. And when that occurs, those areas in the brain do not function as well as they do in a non-depressed brain, and therefore there is an additional risk for that diseased brain to be exposed to neurodegeneration, meaning Alzheimer's disease or any other dementia. So there is a link between the depressive disorders of various sorts and of various lengths and of various recurrence and the outcome which may be very dramatic neuronal loss and neurodegeneration. So that is another reason to be very aware of how you feel and how you want to be treated in order to resolve at maximum the symptoms and the function, in order to be very proactive with your own mental health and not to allow neurodegeneration if it's at all possible. So in women, there is a number of protective factors which men have actually even more benefit with. Again, women are disadvantaged there. And that is the effect of the estrogen, which is the main biological determinant of female physiology, as we all know. And estrogen, in many cases, is protective of the cells in the brain. It's a neuroprotective factor. Now, what happens when woman ages, the estrogen levels decline, and sometimes they decline very rapidly and precipitously, especially if it's a surgically induced menopause, or more gradually in a natural menopause. But at the point when woman stops her periods, it's a time when the actual fluctuation in estrogen levels is accomplished and the actual concentration is very low. So men do not have that problem. Men have much steadier and more even distribution of levels of estrogen in the brain because they have testosterone, and testosterone does not go through such rapid and precipitous decline in the male body as estrogen does in the female body. And therefore, in the brain, testosterone becomes estrogen and then is also neuroprotective. So men, when they age, preserve certain cognitive domains much better than women do. And women who use estrogen because of whatever reason they were prescribed by their practitioners in menopause may have a certain advantage over those women who do not use estrogen with regard to the neuronal protection. And that is a very convoluted area, currently still under review, but if you'd be interested, I can talk a little bit more about that. The bottom line here is that estrogen is in itself an antidepressant, and it's not as effective antidepressant as, for example, Prozac or Zoloft or other antidepressants are. However, in some cases, estrogen alone can ameliorate depression when woman goes through menopause. And in some cases, when it's not enough, giving estrogen to an antidepressant may facilitate the antidepressant response. So here are the data. It's coming actually from our group, and these are brain imaging slides I wanted to bring to you and just show you a little bit what's going on in the brain. So the brain imaging is the probably most exciting technology available in psychiatry right now, just because it allows you to see the brain when it's functioning right now, and there is ability to determine the cerebral blood flow or the cerebral metabolism. This is the brain of a patient who is depressed, who is postmenopausal, who has no endogenous levels of estrogen much, and is not receiving any estrogen or any other hormones. And this is the woman who is not depressed, also postmenopausal, and also does not take any hormones. And you could see that the woman who is depressed has less blue here, right? You could see that. And the woman who is not depressed has more blue here. And that color, the intensity of that color, tells us that there is more metabolism. So there is more glucose available to the brain in those who are not depressed in the absence of estrogen. So just being depressed in certain areas of the brain, again, some of the areas are very important for affect regulation, some areas are very important for cognitive function, etc. But woman who is depressed is not having as much glucose available to her brain as the woman who is not depressed. Now, if you will look at woman who is, now these are both depressed, both non-depressed. This woman is not on estrogen, and this woman is on estrogen. And again, now you look at this area, there is no blue whatsoever, and this is the area with a certain amount of metabolism. And that is again an evidence that now just being on estrogen makes more glucose available to certain regions in the brain. Here's another little presentation of the metabolism. Now these are not depressed patients. These are patients who are using estrogen and not using estrogen. But now these are not just the snapshots at one at a time, but before and after. This is the baseline snapshot of the glucose metabolism in the brain, and this is 2 years later. So this is in an area which is responsible for memory and one of the first areas which decline in Alzheimer's disease. And these are women who do not use estrogen, so you could see that at the baseline, non-estrogen user and an estrogen user were not that different. But here's what happens to a woman who does not use estrogen. You could see that basically the red in this case is almost all gone here. And you could see that this woman who was on estrogen in 2 years preserves this amount of glucose. So there is a certain notion, not saying that it's truly a rule of thumb, but there is a notion that in aging women, at certain point in their transition into aging, if they receive estrogen, they actually may preserve metabolism in certain areas of the brain. And if they are depressed, their metabolism is also decreased with or without estrogen. So it's very important, again, to keep in mind that mood disorders are having long-term consequences, and they clearly need to be very aggressively treated and aggressively worked with as a member of the family, member of the community, or a physician. So I'm going to stop in a minute. I just want to show you some kind of conclusions from what I was just trying to describe, and then tell you a little bit more about the center which we started and launched 2 months ago. So women are more likely to suffer than men from mood disorders. Having hormone therapy may have better quality of life and preserve certain regional cerebral metabolism and cognitive function. It is very important to identify appropriate treatment of mood disorders in specific populations, because there is no one-size-fits-all intervention. And we do need to identify a group of women who may benefit from the use of estrogen in cognitive aging. So here's the reason why we created this center, because we thought that it's going to be really a one-stop shopping for clinical services, training of young physicians, psychologists, and other mental health providers, and research unit. I don't know if you can see it well, but the Stanford Center for Neuroscience and Women's Health is comprised of a number of entities. So this is the Infertility and Perinatal Psychiatry Research Group, which works with mothers who have mental illness and who may actually have certain conditions which could be transferred to their children. We have obstetrics and gynecology and perinatal consult service, where we actually see patients in the hospital in acute situations specific to the reproductive events. Usually these are women who are pregnant or have obstetrical complications and mental illness. And we have a clinical entity in the Department of Psychiatry called Women's Wellness Clinic, and that is the main clinical hub for all the services we provide for women and their partners and their families who have mood disorders. We also have a research unit where we'll look at various extrapolations of hormones and other chemicals in pathophysiology of mood disorders and aging process. And we have a completely new program where we provide non-pharmacological intervention such as family therapy, couples therapy, individual therapy, psychoeducational classes, etc. for mood disorders of women of childbearing age. We also have completely new lab for the neurocognitive assessment for aging persons, not specific to women, to men and women alike, when we may provide a comprehensive evaluation and then psychoeducation about what is going on with their function cognitively, and provide referrals if there is a more severe intervention necessary. So the question is about the risks and benefits of intake of estrogen in light of results from WHI and WIMS, because WIMS is a memory arm of WHI. Well, that's the good news, because if I were to give you that lecture 5 years ago, I would be crying on the podium, because that was the time when we thought that estrogen was completely harmful to women, and that was based on the first results from WHI. The most current reanalysis suggested that women who received estrogen with progestogen, so prim-pro arm, women who received that in their early postmenopause, meaning ages between 50 and 59, these women did quite well. In fact, the only risk which remained in the reanalysis was with regard to stroke. With regard to cardiovascular disease, it was actually beneficial to them. And estrogen alone arm suggested that with regard to cardiovascular health, it was neutral. So there was no adverse effects of estrogen alone in that younger cohort of women. No, but the stroke was increased. The risk of stroke was increased. With regard to the breast cancer, actually, the news are pretty good there too, because if before we thought that the risk of breast cancer is significantly increased in both arms of WHI, now they said that breast cancer risk was neutral or maybe even, and they don't know because they stopped the study early, is maybe even, at least it was in a trend, to decrease in women, again, younger postmenopausal women who received estrogen alone. So basically what it says is that when a woman goes through menopausal transition and receives estrogen for whatever reason she is receiving it, it's not as harmful and maybe actually beneficial than if a woman starts it later in life. So women who started estrogen after age 60 probably should not start it, because what we realize now that these women not only not benefit from it, it could be harmful. And that is something, you know, what science gets, because the study was designed 15 years ago. At that time, everyone thought estrogen was better than sliced bread. And now, you know, we're finally coming to a more careful and individualized approach to prescribing it. It's a very potent drug. So, if you were taking estrogen in the past and you talk with your physician about your specific risks and benefits, that's the way to go. So the question is, how is it possible that risk of stroke is increased with the use of estrogen, but it's beneficial for cardiovascular disease? Well, one of the very well-known effects of estrogen is a procoagulative effect, which means that estrogen causes blood to clot. That has been known forever. In some women who are more prone to that, estrogen will definitely increase the development of thrombi, and therefore these thrombi can occur in the brain, can occur in the lower extremities, can shoot up, can occur in the heart, etc., etc. But cardiovascular qualities of estrogen are independent of the clotting factor, and they're associated with lipids. Estrogen is actually somewhat protective from diabetes, which is one of the major vascular diseases leading to the cardiovascular disease, and we all know that. And so there are other types of effects of estrogen which are not associated with stroke. And I think it would be truly a disservice to bring it all together, as it would be a disservice to say that it's good for everyone, because it is not. So the question is to talk more about depression and memory. That's a very long conversation, if to be very specific, but the bottom line is that in many cases when patient is depressed, they have quite often transient cognitive impairment, which is a part of the syndrome of depression. For example, a person is depressed, goes to the grocery store, and stands in front of the aisle with a list of things they need to buy and doesn't know what they need or can't make a decision. And sometimes they just leave the store because they can't make a decision. It's incredibly frustrating. People can't concentrate well enough. People sometimes become forgetful. Now, all these things, if they occur in the context of depressive disorder, may get resolved in the majority of cases if that disease aggressively and appropriately treated with the proper medication or therapy or both, long enough and aggressively enough. In some cases, those cognitive complaints and symptoms and dysfunction persist despite the person is becoming now non-depressed and back to their baseline. And those cases are even more important to follow, because that's when the risk for further progress of the degenerative disease may be happening. And I think that if people know, if people are aware that they had certain deficits in the cognitive domain and it's not resolved, they need to go back to their doctor and talk about that, and then maybe do brain imaging or neurocognitive testing, etc. So the question is about the domestic abuse, and that if in our center we have this evaluation. The answer to that is no. Unfortunately, we don't do that evaluation in our center, but you're absolutely correct. And in fact, I would say that one of the most unspoken dramas and tragedies is the domestic abuse and violence, and not necessarily just perpetrated toward women, much more frequently so, but sometimes perpetrated by the woman towards her children or towards her spouse or her partner, etc. But women are much more often victims of domestic abuse and violence, and what happens is that they are afraid to talk about it. So sometimes you will not even be lucky enough to recognize it unless you have a physical manifestation of abuse. And I can tell you, it was one of the most dramatic cases in my career as a physician. I had a woman who was, when I was in Los Angeles, I had a patient who was incredibly successful owner of a large corporation, who after 5 years of therapy with me came to my office with a little book, and she closed the door. She said, "I don't want anyone in." I said, "Don't worry, it's not going to happen." She opened that little book with a key, and she showed me the photographs, which were 20 years old, of abuse she withstood from her ex-husband. And those photographs, I have to tell you, they would make any cable news really pale in what they show. And this woman never said a word to anyone for 20 years. And she was still afraid even to tell me after she saw me weekly or twice a week for 5 years. So abuse is a horrendous thing. It happens a lot. People are not prepared to talk about it very often. And there are certain centers which provide that type of relief and evaluation. We do not. So the question is, what is the difference between the bipolar disease and other types of depression? So if you were to think in a very graphic term, what happens when a person is depressed? So you could think of some kind of a hypothetical baseline of mood and functioning with periodic decreases in functioning. So if you were to draw it, it would be a line with a dip. And then after a certain period of time, the line would go back to the baseline, or maybe just a little bit under the baseline, but would go from the baseline down. With regard to the bipolar illness, there is what is called another pole of that illness, and that is the periods of the elevated mood, which not necessarily has to be elated. So the old notion of bipolar disease being this very dramatic, euphoric manias when people think that life is great, that they're in the top of the world, it still happens, but it's not as common. When people feel more often more depressed and more frequently depressed, and then they're interspersed with those periods of irritable and impulsive anxious mood, which goes above the so-called this hypothetical baseline, but never really reaches the level when they are behaving very erratically. A lot of people have different gradations, a range of expression in those symptoms intensity, and therefore every bipolar patient has different course and different presentation. But the most easy distinguishing thing is that the mood goes above the baseline, not goes just down. So the question is about the correlation between the sleep and depression. There are a number of centers around the world studying effects of depression on sleep and sleep disturbances in depression. And it's very well known that there are two types. I mean, it's kind of a little bit ambivalent for me to say, but they're both sleep disturbances as an insomnia or lack of sleep, and hypersomnia or excessive sleep in patients who have depression. There are different types and different presentations. Women are more often oversleeping, men more often undersleeping. But it doesn't mean that women always sleep more than they want to sleep. In some cases, it's called atypical depression. They sleep longer hours than they want, and they have very hard time getting out of bed. But sleep is definitely one of the crucial components of the depressive syndrome, and in fact, there is a fairly limited application to apply sleep disturbance to a depressed patient with an idea that they may improve in their depressive symptomatology. For example, if a person has depression and sleeps too much, if you deprive the patient from sleep during the night at a certain hours, and it's done in a controlled way, their mood may get elevated. I have not seen a patient who would just do remarkably well on that method alone. It usually doesn't happen, but it can sometimes help. Alternatively, in patients who have bipolar disease or manic depressive disease, lack of sleep may instigate and quite often is the main trigger for the hypomanic or manic episode when the mood goes off into the highs because they did not sleep enough. So the question is about the condition of neonates.
Yes, except that there when
Or neck condition, the torticollis. Torticollis, it's basically when the baby's head is turned in a certain way and the baby is not rotated and attended well to, the neck gets rigid and kind of turned to the side. It's a great question. So the question is, if to follow my song and dance, if estrogen is good for the mood, and when a woman is pregnant she has a lot of estrogen, wouldn't pregnancy be in a way protective from depression? That was a notion in the literature for about 25 years. And until we had systematic studies, we did not know that actually it's not protective. And in fact, the incidence, so the rate of new diagnosis of depression is not different between pregnant and non-pregnant women. And I don't necessarily think that we can write off everything on hormones, because I think it would be a terrible disservice. Of course they have high levels and sustained levels of estrogen, but so they have of progesterone, and progesterone is exactly doing everything opposite in the brain and unfortunately in the heart than estrogen. So you can't take one hormone out of the constellation of various things and say that that's what will work and what will not work. We do know, however, that women in the pregnancies which are well protected, have very strong social support, family support, etc., they probably have less risk to develop depression, but that would probably go for any woman being pregnant or not. So the question is, how come we're offering something which other physicians never suggested for people who have depression? Who is responsible for providing neurocognitive assessment or brain imaging, etc.? Okay, that's not a standard of practice. What we're providing in our center is not a standard of practice. It's excessive, it's above what usually is done, and usually psychiatrists do not suggest neurocognitive assessment or brain imaging unless they think that there is some kind of a reason to rule out pathology with that specific additional testing. That means, unfortunately, that insurance companies may not pay for that type of evaluation, and what we're trying to provide in this center is maybe it's not fair, and I'm fully aware of that, and I take responsibility for that, but somebody has to start, and I wanted us to start. We were providing state-of-the-art, not state-of-the-practice evaluation. And the reason we're doing it is because we're keenly aware that certain small, subtle changes can occur early on, and then we have to, sometimes they will not be picked up by neuropsychiatric assessment. but sometimes they are, and even if they're small, and we will provide people with tutorials how to learn to deal with those and how maybe to undo them. That would do more good than other interventions. So that's what we're trying to do. We're just at the beginning of it. We cannot provide it to everyone. We will be providing it on an individual basis. But neurocognitive assessments are going to be available with anyone who will come in. Whether it's going to be covered or not, it's going to be not up to us. It's a fantastic last question. So the question is, if you have a loved one or a family member who may have severe mental illness, being it depression, bipolar disease, or whatever, how do you approach them? Well, I have to tell you, there are also gender differences in the way men and women manifest depression. Women will be much more verbal about it. Men will do more behavioral modification. Again, it doesn't mean that it's uniform, but women will go to see a doctor. They may not say to a physician, you know, I'm really depressed and I think I need an antidepressant. They can say that they have heartburn, stomachache, constipation, poor sleep, whatever. It could be very, very physical in the presentation. Men will hardly ever go to see a physician for that. Men will go to the bar, or they will go and, you know, sit in front of television and do nothing else. They can withdraw, and it's much more difficult because when men withdraw, women have very hard time relating to that, and they suspect completely different, sometimes constellation of reasons behind it. So the best thing to do is to try to establish some kind of a line of communication with non-threatening concerns by just saying that I observed that certain things were not going the way they used to, and I wonder if you have an idea what's going on, without specifically confronting the problem by saying, you know, I think you're really, really depressed. The only place where I would say the person has to be very proactive and not afraid to confront directly head on is there is a suspicion that that person in question may be a danger for their lives. And that is something where people exhibit with their behavior, sometimes subtle, sometimes not so subtle, and it's really a cry for help. And it's important to approach it head on and say, do you feel like you are not safe? And if that's the case, I would definitely urge anyone who encounters that situation to immediately call police and or bring them to nearest emergency room by themselves, or to bring them to mental health professional who can exert their ability to protect the person.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.